Good evening, friends. Welcome to the 31st edition of Amasi online CME program. This is one of the very popular programs organized by Amasi. And today, amongst us, we have a prolific surgeon and also the president of HSI, that is Hernia Society of India, Dr. Vijay Borgaonkar, sir. And he would be talking to us on GERD, Hiatus hernia, and the surgeon. So to moderate this session, we have Dr. Rajesh Srivastav and Dr. Abhimanyu Basu from Kolkata. And shortly, Dr. Parsati will be joining us. And I also welcome our coordinator and convener for this program, Dr. Rajdeep Singh and Dr. Jayanta Das, who's the zonal president of East Zone. Welcome you all for this and eagerly waiting to hear some good insights from Vijay sir. Over to Dr. Rajdeep.
Yeah, so Dr. Jayanta, would you like to introduce the moderators?
Good evening to all. So this will be a very interesting session on GERD, hiatus hernia, and the surgeons. So to moderate this session, we have three eminent surgeons: Dr. Rajesh Kumar Srivastava, President West Zone, Amasi from Gujarat; Dr. Abhimanyu Basu, he is the HOD, IPG MER and SSKM Hospital, Kolkata; and Dr. R. Parthasarathi is the HOD, JAM Hospital, Coimbatore, Department of Upper GI. So he will be joining a little late. So other two are here online. So over to you, Rajdeep, sir.
Thank you very much. And like our secretary, Dr. Roshan mentioned, we have a very eminent personality today, Dr. Vijay Borgaonkar. He is the president of the Hernia Society of India, possibly the biggest hernia society in India. And he is very well known for a wide variety of procedures. He is working at Krupamai Hospital, Aurangabad, now known as Chhatrapati Sambhaji Nagar. And he is exceptionally well versed in the nuances, the intricacies of GERD and hiatus hernia. Anybody who's ever heard him will go away enlightened and learn a lot of things which I'm sure many of you would not have known before. He's had delivered a number of orations all over the world, and it's my pleasure to hand over to Dr. Vijay Borgaonkar for his talk on GERD, the hiatus hernia, and the surgeon. Over to you.
Good evening, everyone. I am extremely thankful to Dr. Rajdeep Singh for a nice introduction. I also welcome Dr. Shetty, Dr. Abhimanyu Basu, and Dr. Jayanta for this to moderate this session. I bring greetings from the Hernia Society of India and also from Krupamai Hospital, where I work at Aurangabad. The topic that we are going to discuss today is the GERD, hiatus hernia, and the surgeon. All the cases of GERD, they may not have the hiatus hernia. All the hiatus hernia cases may not have the clinical signs and symptoms of GERD. And surgeon plays a very pivotal role, and he has got great responsibilities before he chooses a patient for any surgical procedure, because the invasive procedure that we do for such cases is almost irreversible for that matter. For simplicity of the understanding, these are the four types of the hiatus hernia, as we all know, and type 1, type 2, type 3, and type 4. What I have done is, I have put this type 2, 3, and 4 in one bracket, and I have segregated the type 1 hernia in the another bracket. The point here is, out of the hernia cases, hiatus hernia cases, only 10%, the type 2, 3, and 4, they contribute only 10% of the total hernia cases, hiatus hernia cases. All these patients, they did not present with the GERD-like symptoms. Rather, they have got symptoms of the mechanical compression, All these patients, they require imaging like CT scan for the perfect diagnosis. And almost 100% of these cases would go for a surgical intervention. So the investigations like a manometry or a pH-metry, they may not be needed for these cases. Now let us look at this type 1. This type 1 type of the hernias, they contribute to almost 90% of the cases of the hiatus hernia. Out of this 90%, hardly 10% they require surgery. So now, hereafter actually, I would concentrate your attention only to this type 1 hernia because they have got symptoms of the GERD. And from here, we have to pick up the patient correctly for any surgical procedure. And we must also do the investigations like manometry and the pH-metry. Let us go step by step. Large number of population, nearly 25 to 30% suffers from symptoms of the GERD. And there are typical symptoms and there are atypical symptoms. The typical symptoms are only three: heartburn, chest pain, and regurgitations. If the patient has got these typical symptoms, perhaps we can straight away go ahead with the PPI treatment. And the patients who are non-responsive or something like that, then these patients might warrant a surgical intervention. Or if they are complicated by these symptoms, like say patient is getting a Barrett's or there is a stricture esophagus, then of course surgical intervention is required. And what happens is that generally we lose attention towards these atypical symptoms. These atypical symptoms are the pharyngitis, laryngitis, globus or the pain in the throat, change in voice, paroxysmal nocturnal cough, and belching. And there are many other symptoms like that. These atypical symptoms, they need full battery of investigations like manometry or even the pH-metry, because here we want to prove that GERD is not the reason for these symptoms, or we have to prove or disprove. If it is proved that GERD is the reason for the laryngitis or the change in voice, then perhaps these patients, they need some sort of a surgical treatment. There are certain alarm symptoms and for which nobody should wait for performing an endoscopy, like weight loss, dysphagia, and the GI bleed. They need upfront upper GI endoscopy. In short, all the patients with typical symptoms, they qualify for PPI therapy. The patients who are not responding to the PPI or they are refractory to PPI or they are dependent upon PPI, they might need surgical intervention. All the patients with atypical symptoms, they need further investigations to prove that GERD is the cause for their symptoms. Now, these are the diagnostic tests that they are in our armamentarium: endoscopy, imaging, high resolution manometry, impedance pH-metry, and nowadays even the endoflip has come in the GERD. Now, I told you that the type 2, 3, and 4, they will need an imaging like bariums and the CT scan to come to a correct diagnosis. However, the type 1 type of a hiatus hernia or GERD symptoms, they will need rest of them. And then there is a definite place for every investigation, and there is a definite limitation for the every investigation. We'll go just one after another. Now, if we do an endoscopy in a patient of typical symptoms, then we can only get, we should know these three things when we do the endoscopy. The first thing is that whether the patient is suffering from esophagitis, and then there is a Los Angeles classification of the esophagitis. If the patient has got Los Angeles B, C, or D, then this is taken as a positive factor. It's taken as an actionable GERD. The esophageal strictures, like this is now here, there is a Schatke's ring here and there is a stricture here. And this is like a Barrett's if you find on endoscopy. Then all these things, they contribute or they suggest us that we have to do something for these patients. And these are the actionable GRD cases. In Los Angeles, typically type A or Los Angeles type A, it has been excluded from this Los Angeles from this Lyon's criteria. Now, this gives us to the actionable GRD. Now, what is the actionable GRD? This is the long-term medical treatment, or then you have to develop the dose of the PPIs. If the patient is not responding, then interventions may be endoscopic in the form of the arms procedure or any other endoscopic stitch, GERD stitch procedure, or the laparoscopic Nissen's fundoplication. It is required. If you look into this picture here, then if we perform an endoscopy with patients of GERD, only 35% are positive in our routine practice. Almost 65% of the endoscopies that we do, they have no positive finding on the endoscopy. They are normal endoscopies. So this endoscopy positive is only 35%, and these are called as the GERD. These are the erosive GERD, the gastroesophageal reflux disease, out of which 30% are erosive, 5% could be complicated in the form of strictures or the Barrett's. The whole lot of this 65%, they do not have any erosions in the esophagus, but they still have symptoms of reflux disease. They are called as the NERD, the non-erosive reflux esophagitis. And in this non-erosive reflux esophagitis, the 40% are NERD, 20% are having the acid hypersensitivity, and 20% are having the functional heartburn, and there are some percentage where they have a non-acid hypersensitivity. Now, all our attention should now go to these NERD cases, because at least 20% of these NERD cases, they would require a surgical management. And we must pick up the cases correctly. By mistake, we should never operate upon the patient who has got a functional heartburn. We should never operate upon the patient who has got an acid hypersensitivity or a non-acid hypersensitivity. And these patients we can pick up by performing certain sensitive tests which are now available with us. If we do an upper GI endoscopy, there are two ways by which we can know that whether the patient has a hiatus hernia or not. A common thing is that if there is a G junction and the diaphragmatic clinch, the distance is more than 2 centimeters, this is a hiatus hernia. But when we do upper GI endoscopies, most of you must be doing it, we find that the patient is always retching, he is not comfortable, and whenever there is a retching or belching while doing upper GI endoscopies, the G junction goes up and down. There is excursion of nearly 4 to 5 centimeters. So the axial length that we encounter or we see, it may not give us a correct clue that whether a patient has got type 1 hernia or not. For this purpose, this Hills classification is better, and it is Hills grade 1, grade 2, grade 3, and grade 4, depending upon the size of the hiatus here and your scope. Here the scope is just size of the hiatus. Here the hiatus is opening with inspiration and expiration, but it is again closing. Here the hiatus is large, it is grade 3, and this is grade 4, where you can see the entire lower one third of the esophagus if we do a J turn in the stomach. For your information, the Hills type 1 or grade 1 and grade 2, these are normal. Type grade 3 and grade 4, they are abnormal. So if you happen to do an endoscopy, you never label that there is a grade 2 hiatus hernia, because that is grade 1 and grade 2 is normal. So if you write on the report that patient has got a hiatus hernia, then we are giving a little wrong message to the patient, and then he can get apprehensive because of that. Some patients, after these endoscopies, then we need to do the high resolution manometry. And I will just introduce you this equipment, how we perform and what is this equipment. this high resolution manometry, it has got some components, and here you can see a jar, and it has got a inlet and an outlet. Now the jar is filled by at least 2/3 of the jar is filled up with the boiled water when you start the case. Why boiled water? Because all the air bubbles in the water should come out, and there should be no air bubbles in the micro bubbles left in the water, which is being used for the manometric purpose. And then this water is pressurized with 1 bar of oxygen. So this tube will give a pressure of 1 bar of the oxygen on this water, and then there is an outlet here, and this outlet is connected to a insertion tube which has got 16 channels, and these 16 channels, they perfuse the water under 1 bar of pressure, and these are now connected to this system. There are transducers here. These transducers can monitor the pressure that is being generated, and that is seen on a manometric graph here digitally. So this is the insertion tube, and it has got 16 channels as you see here, and this every channel has got one opening here, so that when we start perfusing the patient with this, the water bubbles will come out from these small tubes, and this tube is placed in the esophagus. The resistance to the fluid that comes out from this tube, the resistance imparted by the esophagus will give rise to the pressure readings. Now, what are the indications for the high resolution manometry? Not every patient we need to subject for the high resolution manometry. This is to evaluate a non-cardiac chest pain. If the patient has got retrosternal pain, the cardiac causes have been ruled out, so then perhaps he has got some problem with the esophagus, and then we can do the high resolution manometry. Evaluation of non-obstructive dysphagia like achalasias, evaluation of patient undergoing surgery for the GERD. This is especially to find out whether the motility of the esophagus is normal or not. We are going to talk about this point in little detail in future. And this is the prerequisite for the pH metry that we might do in future. Why it is a prerequisite? Because it is only by the high resolution manometry we can know exactly the level of the lower esophageal sphincter, how much it is from the incisors. And we have to place the pH metry catheter 5 centimeters above the LES or the lower esophageal sphincter. And that is why manometry becomes a prerequisite for performing the pH metering. And then in post-operative cases of the fundoplication, we can perform the manometry if there are some problems which arise after the fundoplication. We can't proceed without paying our tribute to Sir Claus, because he has given this fantastic picture to us, the picture of the high resolution manometry. See, what happens is that when you put the catheter tube here in the esophagus, here on this axis we can know at what level we are talking about, whether it is the 15 centimeters, 20 or 40 centimeters like that. So on this axis we have got the distance in centimeters. On this axis we have got time in seconds. And we need to know one more parameter, that at what level, how much pressure is generated in the esophagus. And this third dimension cannot be seen on the X and the Y axis. So these colored things that you see, these are the pressure topographs. So as the pressure is generated like that, the wave is coming down. And if these pressures are given or assigned a typical color, for that matter, dark blue color, which is the very cold color, it is a low pressure, and the warm colors like the green, yellow, red, and even the black, these are the warm colors, and they give the higher pressures. So just by looking at this wave, we can know that how much pressure approximately is generated at which level and which are the pressure bands here. And this is the typical picture of the high resolution manometry. It is said that one picture is equivalent to 100 lines. Actually, this picture is equivalent to 1,000 lines, I believe. Because just looking at this one picture, we can come to know several points in the esophagus and all. Look at this here. This all blue is a low pressure zone, definitely. And then we can see a color band, high pressure band here. Naturally, this is the upper esophageal sphincter. There is another parallel band here like that, and that is the lower esophageal sphincter. If you look at the upper esophageal sphincter here, this is the pressure zone here. Now, again, there is a blue color. That means there is a break in the pressure, and again, there is a high pressure zone. So here what has happened is patient has taken a swallow. The patient has taken a swallow, the sphincter has relaxed, the pressure has dropped. And now this bolus is passing into the esophagus like that. Initially, 1/3 of the journey is facilitated by the cricopharyngeal muscles. These are the skeletal muscles, and the bolus is pushed with force into the lower esophagus. And thereafter, there is a transition zone, and then the peristaltic function is taken over by the smooth muscles here. So this is the transition zone. This is also called as a peristaltic break, and this is the smooth muscle here. Now, if you look at the lower side here, this is another pressure zone that we can see here. This is the lower esophageal sphincter. And then we can exactly measure that how much is the distance of the lower esophageal sphincter. Now, this is the lower esophageal sphincter. And again, you find that there is a blue color, so the pressure has dropped. That means the sphincter has relaxed to facilitate the passage of the bolus here. It is a fantastic bioengineering. The moment upper esophageal relaxes for a swallow, it could be any swallow, even your salivary swallow, maybe 2-3 ml of swallow, any small swallow. The moment there is a relaxation of the upper esophageal sphincter, instantaneously there is relaxation of the lower esophageal sphincter. This is normal physiology. This should happen always. So thousands of times we have a swallow, this mechanism is going to happen. And then again the swallow has cleared, and then this is the lower esophageal sphincter here. Now this is the lower esophageal sphincter zone, and in between you find that there are some high pressure bands in between. And these are the bands of the respiration, the clinch of the diaphragm. So if you ask the patient to stop breathing for some time, then these bands will disappear. And in this case, the lower esophageal sphincter and these bands, they are coinciding. So there is no dissociation of this band, the diaphragm and the lower esophageal sphincter. So this is the normal high resolution manometry. The waves that you see here, these are because of the pericardial pulsations. It's a very sensitive equipment, and very small changes in the pressure will be reflected in the manometer. Now, it is very pertinent to understand that what information we really want to extract after we do this high resolution manometry, or if you send a patient for the high resolution manometry, then what information your gastroenterologist should feed you. I tell you, this is the most sensitive and the most accurate in the diagnosis of the hiatus hernia. As you have seen in my previous slide here, that there is no dissociation here, so there is no herniation. Even a slightest dissociation, that means we can know it on the high resolution manometry. If the dissociation is more than 2 centimeters, we say it is the hiatus hernia. Incidentally, this virtue of high resolution manometry, that being more sensitive and accurate in the diagnosis of hiatus hernia, is not applied in clinical practice. Because if you diagnose a dissociation of 2.5 centimeters on manometry, this does not become an indication for undertaking any surgery for this patient because you have diagnosed a hiatus hernia. So just diagnosis of the hiatus hernia on manometry, we cannot proceed for the surgery unless we have got many other points which are there for our thinking. So this virtue of the manometry, that sensitive and accuracy in the diagnosis of hiatus hernia, is used for the research purpose. The second information the manometry gives us about the esophageal peristalsis, and it tells us whether there is ineffective esophageal mobility, and if it is so, then we can refrain from doing a 360 degrees fundoplication for that matter. But this point I'm going to talk to you in little more detail. And the third thing is it gives us a phenomena called as the transient lower esophageal sphincter relaxation. This phenomena can happen in many normal individuals. What happens is that even if patient is not taking any swallow, the lower esophageal sphincter is relaxing and there is a regurgitation. So anytime there is a relaxation of the lower esophageal sphincter, the gastric contents can regurgitate into the esophagus and they can give the symptoms and signs of the GERD. So that is another phenomenon. And last thing I have already emphasized that it gives the exact location of the LES. So these are the only 4 points that high resolution manometry gives us. Now, when we talked about the ineffective esophageal mobility, we must understand what is the normal swallowing mechanism or what are the factors which contribute to the normal swallowing. The swallow is pushed by the pharyngeal skeletal muscles with force because these are skeletal muscles. We take a swallow and food goes with force into the esophagus. There is simultaneous relaxation of the lower esophageal sphincter. That means there is a vacuum there, so the bolus is now getting sucked because of the negative pressure in the lower esophageal zone. There is contraction of the longitudinal muscles of the esophagus, which results into shortening and it pulls the OG junction proximally towards the hiatus. See, the moment there is a swallowing, the longitudinal muscles of the esophagus, they contract, and so that they contract so that the LES is pulled at least 4 to 5 centimeters, 6 centimeters, so that the transit, the distance, the bolus which has to travel, it is less in centimeters. The density, viscosity of the bolus, it matters very much. It is very difficult to swallow air. However, a well lubricated or a good density bolus food we can swallow very well. The posture is also important. In a lying down position, our swallowing mechanism becomes less effective. If we are upright, the swallowing is more effective. And the last factor that helps is the contraction of the circular muscles of the smooth muscles. So this is these are the most important contributory factors for the swallowing. And the peristaltic movement of the esophagus, which is imparted by the circular muscles, I have put it at the last factor. So having all these factors normal, even if there is less contraction or there is a less contraction of the smooth circular muscles, these factors can take over and the bolus will be pushed down. And that is why the threshold of ineffective esophageal mobility has been raised to 70% in Chicago 4 classification. Earlier, if the 50% of the swallows, they are abnormal or they are ineffective, the patients were taken as the ineffective esophageal mobility and they were refrained from doing a 360 degrees fundal wrap. However, now with Chicago latest classification, Chicago 4, the threshold of the IEM, it has been raised to 70% looking at all these factors which I told you. Now here is the normal high resolution manometry. This is the LES and there is a diaphragm, they are coinciding, there is no hiatus hernia. And here, these are the contractions of the diaphragm. And here you can see the lower esophageal sphincter. So there is a hiatus hernia. So this we can diagnose on HRM. The ineffective esophageal mobility, it can be diagnosed on high resolution manometry, but remember, IEM is observed in 10 to 15% of the normal individuals. What is important is the bolus clearance. And that is why even if 70% of the peristalsis are showing ineffective in mobility, still we can proceed with our surgical procedure. The important thing is we must understand whether the bolus is getting propagated properly or not. And for these two things, for this, we have got two more tests which have come to our rescue. And one is the MRS, it is the multiple rapid swallows, and the second thing is the rapid drink challenge. If you get a manometry report without the report of the MRS, then we can insist for getting this MRS report for the because it is the most important thing that's what I feel. If you have say 80% of the swallows which are ineffective, the patient is young and patient has a good bolus clearance, you cannot say that because it is 70%, so there is nothing like cutoff for that matter. And for this purpose, we must do this multiple rapid swallows test. Now here you look at your patient has taken a 5 ml swallow and look at the pressure that is generated here. It is about 1450 millimeters of mercury per second per square. So it's called the distal contractile integral. So the pressure in this complete zone, it is 14 and 15. However, if the same patient is given multiple swallows at short intervals, and now look at how much pressure that has been generated. It is nearly 4,199, this DCI in this case. If the patient doesn't exhibit this phenomena, then the patient definitely has got ineffective esophageal motility, and we must refrain from doing the 360 degrees fundal wrap. Normally, there is augmentation of the DCI after MRS. Absence of this phenomena after MRS is indicator of possibility of post-operative dysphagia after anti-reflux surgery. So this is a very important test that has come to our mind now. The second thing is the rapid drink challenge. This rapid drink challenge is because you look at here, the patient has taken a swallow and it has gone down, and we are not very clear that whether shall we label this as an achalasia or not, because the IRP is 12, the cutoff IRP is 15, as you know. This we don't know exactly that whether to label this as an early achalasia or not. Give this patient a drink swallow of about 200 ml swallow and then see what happens. The things that you see here, they are much exaggerated here now. So the early achalasias or the early phenotypes of the achalasias, the phenotypes in the sense of eosinophilic esophagitis and many other things which happen at the lower esophageal sphincter, these are the phenotype of the achalasia or very early achalasia. It can be made evident by doing this rapid drink challenge. If you have done a fundoplication, and if the patient has got post-operative dysphagia, perhaps it is also possible that you have missed a very early achalasia if this test is not done. And this is the phenomenon of the transient lower esophageal sphincter relaxation, that there is no swallow happening here, but still the lower esophageal sphincter has relaxed and then there is a reflux. So this can happen multiple times in an individual, and then this can be seen on the HRM. And if it is happening and patient is getting the GERD, then we can consider him for an anti-reflux surgery. These are the tracings of the achalasia cardia, and typically type 1, type 2, and type 3. The patient has taken a swallow here. There is no peristaltic wave, type 1. The patient has taken a swallow, and then there is a pant pressurization right from the upper esophageal sphincter to the lower esophageal sphincter. A full pressurization is there, it's type 2. and there is segmental pressurization is a type 3. And I was fortunate to have been taught by Professor Edinburgh from Australia, and he's a pioneer for developing this software. He had been to Sambhajinagar at our place to deliver a lecture, and we could interact with him and get some good clues. The indications for the pH metry. Not all the patients of GERD they require pH metry studies. The patients with NERD, non-erosive reflux disease, the patients with atypical symptoms, they require the pH metry to find out whether there is a acid peptic reflux and the symptoms association. And of course, to evaluate the response to the medical treatment. The patient is on PPIs, and if there is no clinical response, then we can evaluate this further, that whether there is really acid suppression or not by doing the pH metry in such cases. And then there are two types of the pH metry. One is the conventional, and the second is the wireless pH metry. I have put this together in one bracket because essentially they give us the same information. This is a conventional catheter with a sensor here which can monitor the acid pH level. One sensor in the esophagus, 5 centimeters above the LES, one in the stomach. And then number of reflexes they are happening, we can just monitor here. The same information is given by this wireless capsule. It has no advantage over the conventional pH metry. The only advantage with the wireless pH metry is that it can be tolerated by the children because there is no nasal catheterization, and it can be left for 3 to 4 days if you want to study the patient for longer duration of time. However, the disadvantages are it is costly, it needs anesthesia, it needs to be placed endoscopically, so that these are the pros and cons of the wireless and the conventional, but essentially they provide the same information. Nowadays, what we believe more is in the impedance pH metry. And in the impedance pH metry, there are two metrics which are available to us. One is the acid metric, that we can find out whether this is the acid sensor here, which is in the esophagus. One acid sensor is in the stomach. So we can know that what is the pH of the fluid that is in contact. And the second metric that has been added here is the impedance. Now, what is this impedance? Impedance is the resistance. Now, these are the small metallic seeds, and they are connected by a wire, and a very low voltage current is passed in this wire. So whenever the current is passed, and the current will flow from this seed to this seed, and whether the current will flow from here to here or here to here, it will depend upon where is the resistance. If the impedance is high, the current will not flow. The maximum impedance is given by the air, and we understand that if we put the live electric wire in the air, the current will never travel through the air, the highest impedance. If there is a water there, then the current will start flowing. And if the water is now flowing from below upwards, the current will start flowing from below upwards. If the patient is taking swallow, the current will start flowing from the above downwards. So by combining this acid metric along with this impedance metric of physics, we can know now that whether the fluid in concentration is moving from below upwards or it is moving from above downwards. Not only that, what type of swallow it is. If the patient is just belching without any fluid, then there is a marked impedance. The resistance will be much more, which will be seen on the machine. If the patient is refluxing acid fluid, then the impedance will be low. The impedance is higher if the mucosa is normal, because there is a mucosal barrier there, and the deeper cells are not exposed to the electrical currents. If there are micro ulcerations which are not seen on the endoscopy, or if there is edema at the lower esophageal sphincter or the lower esophagus, the tissues are swollen, naturally the impedance will go down. So if the impedance is going much below than the normal, that means that there are micro mucosal breaks which are not seen on the routine endoscopies. And we can now diagnose these micro ulcerations or the micro breaks by this impedance test. So that is the impedance test, and this impedance pH metry is the gold standard. For your information, the cost of the catheter, the conventional catheter and the impedance catheter is not, the difference is not much. So I always do all my cases only on the impedance, and this is not done. The catheter, how to do it? The catheter is put in the pH 4, then it is washed, and again pH 7, and then we have to standardize, we have to calibrate this catheter, and then this catheter is connected to this machine, and it's a portable machine. It has got two small batteries inside, and there are several keys here. Now here comes the importance of the impedance and the pH, because now we can know that if the patient is sleeping, he will press this button so that the machine will record that whatever recording has happened, the patient was in a sleeping position. If the patient is upright, he will press this button. The moment he gets up, he should press this button. If he starts taking some food, he will press this button. At the end of his drink or the food, he will press this button, so that his every act is now monitored by the machine. And then there are three keys again, 1, 2, and 3. And these keys we can assign to the typical symptoms of the patients. They could be simple belching, they could be retrosternal burning, it could be a chest pain, whatever patient says, that you tell him that whenever he has got a typical or any symptom, he should press that button, so that on the graph we will get this sign. We will know that what is happening at that time and what was the pH and whether it was a refluxing and all that. So all these things can be seen on this machine. There are several advantages of the impedance pH monitoring, that it can monitor the non-acid reflux. For your information, if the acid refluxes are bad to the esophagus, even the non-acid reflux is also equally pathological for the lower esophagus. Physiologically, normally, the esophagus is an empty organ. If something is there in the esophagus, it is going to injure the mucosa of the esophagus. So the non-acid refluxes are also monitored by the impedance. If there is an air or gas movement, either the patient is belching or patient is swallowing air, this can be seen on the impedance pH metry. And this baseline mucosal integrity, the MNVI, is again the very important feature that we get from this impedance pH metry. This baseline mucosal integrity is that normally in health, when the esophagus, there is no ulceration, the impedance is 1500 ohms normally. If by any chance the impedance or the resistance goes below 1500, it means that there are micromucosal breaks, and that is why the impedance has gone down. If the impedance is more than 2500, we can straight away rule out that there is no pathology at the lower esophageal junction. Either actually it gives as sensitive as a microscopic pathology. Because in some cases like the eosinophilic esophagitis, otherwise there is no way by which we can know by our equipment that this could be an early case of a lower the eosinophilic esophagitis. In eosinophilic esophagitis, which is the phenotype of the achalasia cardia for that matter, the MNVI will fall down below 1500. And then if you take a biopsy at that lower esophageal sphincter, you can prove this, the eosinophilic esophagitis. And then the last thing is the PSPW, is the post-swallow peristaltic wave. What happens is that normally, if there is a reflux of acid into the esophagus, we get up in the middle of night, and suddenly what we experience is that there is a lot of salivary secretions from the parotids and the submandibular glands, and a lot of bicarbonates are poured into the esophagus, and then we swallow all that. It not only contains the alkalis, it also contains the germinal factors, epithelial factors, which help in mucosal healing overnight. And that is why even if you have a very bad reflux in the middle of night, in the morning when we get up, there is no trace. We are normal, we are fresh. So this is the PSPW. Now, if this PSPW mechanism is not occurring, that means it is not acid reflux. So this is a very important test. If there is an acid reflux, the PSPW wave must be seen on the manometry. But this part of the metric at present is at the research level. But these three things, they are being used in the clinical use. The another thing is we can know the nerve cases, the esophageal hypersensitivity. We can know that even if there is no acid reflux in the esophagus, patient is getting chest pain. That means the esophagus is hypersensitive. And then in these cases, there is no point in giving further PPIs because patient is not going to improve because the esophagus has got a hypersensitivity. And another thing is a functional heartburn. The patients, they have chest pain. And when you look at the manometry and the impedance pH metry, there is no reflux at all. So these are the cases of the functional heartburn. So these cases, we should totally refrain from doing any surgical manipulations because these cases will not find any relief after your surgery. The belching also can be known whether the patient is having a esophageal belching or whether it is a gastric belch. And there are ways by which we can control the belching. If it is the esophageal belch, the simple thing is that it is usually a swallowed air and the patient just burps it out. You ask this patient to keep his mouth closed as far as possible so that no air goes into the esophagus and there is no belch. And the gastric belch, it can also be known by the impedance pH method. In nutshell, if you have got a heartburn and if we do an endoscopy, 30% will show the erosive esophagitis, 70% are normal, as I told you. Now, these normal endoscopy patients, they are the candidates for a pH metry studies. If we do a pH metry study, 50% of them will have an abnormal pH metry test and we label them these as non-erosive reflux disease. 50% of them, it could show a normal pH metry. But still, out of this 50%, there could be a symptom association in 40% of the cases, and this is the reflex hypersensitivity. When the symptom association is negative, it is a functional heartburn. So, till this point, actually, there are indications for surgical intervention, but these cases we should never operate for the benefit of the patient because patient will never get benefit if you operate a functional heart. There are certain metrics of the pH metry. If the 4%, less than 4% of the total acid exposure time, it is a exclude GERD. If the total percent time is more than 4 or between 4 to 6, it is suspect GERD. If it is more than acid exposure time is more than 6, then it is a definite diagnostic of the GERD. The total reflex episodes, if they are less than 40 per day, it is absence of the pathological GERD. 40 to 80 inconclusive as a standalone metric. It has to be supported by some other metric in the impedance. And if the reflexes are more than 80, then it is evident of the GERD. Actually, after all these things, then a score is calculated like a Demester score. And depending upon that, we can take a judgment whether the patient is having a NERD and qualifies for a surgery. This is the MNP I already told you. If the resistance or the impedance falls below 1500, it is a diagnostic of GERD. If the impedance is more than 2500, it is against pathological GERD. PSPW also I have explained. This is the graph of the PSPW. In conclusions, the large number of population, they suffer from the symptoms of the GERD. Algorithmic approach should be applied. You understand the basic physics underlying every investigation. A surgical and the interventional treatment is indicated in select patients, and there they yield the good results. GERD should be treated appropriately to avoid any future potentially serious complications like the Barrett's esophagus or the strictures, and going into the malignancies and so on. And every effort should be made to recognize patients of the functional heartburn and in whom surgery should be strictly avoided. Thank you. We have got 29th Annual Congress of Asia Pacific Hernia Society at Delhi. I request all of you to join us at Delhi for this APHS Congress. Thank you very much.
Congratulations, sir. What a wonderful presentation of manometrial pH metric. With my IQ, I think I have to go to Amasi website 4 or 5 times at least to understand it 100%. But yes, you have explained in such a great way. A few queries which I could just ask you. Number one, is it good to go for a surgical correction of hiatus hernia without manometry?
No. This hiatus hernia, if it is a type 2, 3, and 4, then the scenario is totally different. So here we can, because the patient is presenting with the compression symptoms in the mediastinum. So all these patients, they require surgery. So you do a CT scan and go ahead with surgery. They don't require manometry now. But those the 90% of the GERD, type 1 hernia, they should be investigated thoroughly before you take up for surgery.
Then you said, sir, non-responsive PPIs. So are they a good candidate for surgery?
These non-responsive candidates, they have to be seen on the impedance pH metry. And here what we do is we continue giving PPIs and then we do the pH metry.
Okay.
And then you find out that the acid suppression is really there or not to the desired extent. And then you take a call.
Okay. So if there is suppression, then?
Yeah, if there is a suppression and there is a symptom association, you go ahead with surgery.
Okay. Okay.
See, the acid has to be there in the esophagus. And also patient has to be either symptomatic, which is proven on the impedance pH metry, or he should be endoscopically evident. As I told you, that it has to be Los Angeles B, C, and D, or there should be either a stricture or the Schottky's ring, or there could be a Barrett's. So these are the clear indications for surgery. No problem.
And last question from my side. Is the distance between LES and upper esophageal sphincter matters?
For
planning a surgery?
No, that way actually LES is a hypothetical entity. If we do an endoscopy, you will never find LES.
Okay.
What you see is the diaphragmatic clinch, and many people say that it is the LES. It is not LES. LES is a pressure zone in the lower esophagus, which is imparted by the lower esophageal sphincter, which can be only known by the manometry.
Okay.
By doing an endoscopy, you will never find where is the LES. You will find the diaphragmatic clinch somewhere. LES could be much above that.
Thank you, sir. Over to our other moderator, Abhimanyu boss.
Thank you, sir, for your exhaustive lecture and in which asked us. So I can comment on two and ask you a question. The commenter is whenever we in our practice, in our mind and our clinical practice, we always judge the GERD symptoms very carefully. Number one, the GERD symptoms, whenever we assess only the heartburn, not the compressive symptoms or the pain goes to the back. This is important. And if the patient has the regurgitation, then we definitely ask always that it is undigested food or digested food, so that the other mechanical things can be ruled out by other investigations. And second thing is that we do not do usually routine CT scan. We do definitely manometry to exclude the esophageal dysmotility, endoscopy for any mechanical or any other things, and definitely 24 hours pH metry. These are the routine practice in our thing. Sir, my question is, sir, what are the indications of paraesophageal hernia? Are all paraesophageal hernia should be operated or not?
Paraesophageal hernias, they are type 2, 3, and 4.
Yes, sir.
And as the age advances, the hernia also gradually becomes larger and larger. And some time of the life, they may come to you in emergency. So it is recommended that all these type 2, 3, and 4, they should be considered for the surgery, and patients should be motivated to undergo an elective surgery for these cases.
Sir, how can I classify before operation this type 1, type 2, type 3, type 4? By endoscopy or not?
Type 2, 3, and 4, you can know only by imaging. We can also have some clue on endoscopy as well, because if we have a Hill's type 4 on endoscopy, then this can be, if you see a pouch going higher up, but then it can be definitely diagnosed on the CT scan. So the 10% of the hiatus hernias, type 2, 3, and 4, they need imaging modality for the diagnosis. They have a compression symptoms, and they invariably require surgery in some part of their life.
So, do you suggest a CT scan for every GERD symptoms?
No,
Because
not
patient is not present with hiatus hernia to us.
Yes, the patient has got either typical symptoms or atypical symptoms.
Yes, sir.
If the patient has got typical symptoms, he qualifies for a PPI. If we give PPI, you stop the PPI after some time, he relapses, you do an endoscopy, or you can do an upfront endoscopy as well. The moment you do the endoscopy, now we have got two types of cases, the actionable GRD and non-actionable GRD. So as I told in my slide, if you are having the cases of actionable GRD, you have to go ahead with the actions. The actions are either you have to develop the dose of the PPI, it could be a very long term. If the patient is young, perhaps you will not like to give these long-term PPIs, or then the patient need to undergo either endoscopic or the surgical interventions.
No, sir. Indication of CT scan in GERD symptom cases.
No, as such, normally for this type 1 hernias, there is no need for a GRD. Usually, these patients of type 2, 3, and 4, they have got atypical symptoms. So either they are having cough or they are having some other symptoms, so that we suspect that there is something else wrong. You do a X-ray test, and then we can do a CT.
Okay. Thank you so much.
Responsive patient who are not getting benefit with this PPI and they have GRD, I think they are the patient we should investigate further. This is my thinking.
Yes.
So
Dr.
one
Jayanta,
question,
Dr. Ajib, sir, yes.
so one question from my side. Many of our ENT colleagues, they refer patients with atypical symptoms like some neck irritation and all. Just on endoscopic finding, they see hiatus hernia. So how to rule out those atypical symptoms? That it is not related to the hiatus hernia.
That's why I said that all these atypical symptoms like pharyngitis, laryngitis, globus or pain in the throat, or a paroxysmal nocturnal cough, or suddenly there is change in the voice. So these are all atypical symptoms of the GERD. These people, they need thorough investigations to prove that these symptoms are not because of GERD. If they are because of GERD, then you have to do anti-reflux surgery.
So what will be the best investigation for that impedance?
Yes, absolutely. These patients need to undergo impedance pH-metry. For doing impedance pH-metry, high resolution manometry becomes a prerequisite. So you do it.
So endoscopy first and then go for these, right?
Yes, of course. See, first you have to rule out. Let ENT person rule out his ENT causes. There should not be a post-nasal drip. There should be nothing sinusitis and all. That he has to rule out. And then patient comes to us.
Sir, routinely should we send this patient for pulmonologist evaluation before operation?
That depends upon the case. If the patient has got some bronchial wheeze or anything. Actually, these things are common in children. Many children, they have got GERD, and they present to the.
But children are not common. GERD is not common in children, sir, and hiatus hernia is also
Other
not.
symptoms.
No, GERD is there. GERD is there. That's why the Brevo capsule and all, they come only for the children actually. GERD is there with the children. They have got a rumination syndrome also is common in the children. So all these things, they need evaluation. One of the common cause for the asthma in pediatric age group, it could be a GERD.
Reflux, yes.
So one more question in relation to Dr. Rajesh's last question. So this LES, while you operate a patient of GERD, you go for fundoplication, you keep at least 3 centimeter inside intra-abdominal esophagus. So does the LES area has got any relation to it, that if the LES you find little higher up, you have to keep it more down?
So that's why we say that we mobilize the esophagus well, and then we bring down the GE junction well below the crux before we do a fundoplication. So all these things are there to see that the LES is below the clinch of the diaphragm.
Sir, another technical question. Do you have experience of using the mesh at the hiatus?
It's a very controversial. I have not used mesh so far. There are
no, because you have vast experience, so I have asked you.
No, I have never used mesh in that area.
Okay,
and again, one question, sir. Do you have encountered short esophagus in your practice in your lifetime?
Not many actually, but then one patient had a stricture esophagus, which we dilated well. Also used triamcinolone for the dilatation and all, and then we performed the Nissan's, and the patient was well. But then not really the short esophagus where you have to do the gastroplasty and all that.
Yeah. So these all are, I think, more of theoretical than practical, because
practical is to rule out the esophageal motility. That's very, very important.
Yes.
The only thing you bother for is there is an esophageal motility disorder or not before jump for the Nissen Fando. That's the thing.
I can see our endoscopic boss Sopimat Saab is here. So, sir, any comments, Dr. Sopimat sir?
No, I was just thoroughly enjoying, and I share your confusion. I need to go through this presentation again and again to understand the manometry. I, of course, as an endoscopist, we relate the symptoms with the findings before we proceed for anything else. That is our general concept. Combination of symptoms with the findings. And many times you may not be able to explain the symptoms with the findings. Many of these patients do have a functional overlay in our experience. That is a very, very, very tricky situation to take a decision in this patient. Of course, manometry, to understand the technicality, I think I need to spend time again and again, as you said. It's an
Vijay sir
excellent thing. I enjoyed.
Vijay sir is too good gastroenterologist than a surgical field.
Yeah,
Sir is
I was.
master of all. He does transplant and whatever not.
Yes.
If I could ask a few questions, please.
Rajib sir, please.
Yes.
Sir, after fundoplication, if the patient continues to have symptoms, does HRM and pH metry help in those cases also?
Yes. After fundoplication, also we can do the high resolution manometry, and there we can pick up some disorders. Even sometimes, as I told you, that one of the cause for the dysphagia after the fundoplication could be an early achalasia that you have missed. So if you have not done that RDC, the rapid drink challenge, then you might miss a very early achalasia or a phenotype of the achalasia, which is the eosinophilic esophagitis. It is not very uncommon for that matter. Once in a while, we have a case of eosinophilic esophagitis.
So anything about the ineffective motility? I mean, my things got much clearer from your talk today regarding the ineffective motility. So my question is that you said that if the bolus clearance is there, we can still go ahead for surgery. But do we change the type of procedure? Do we do a partial, or a Nissen is also okay in those cases?
Yes, this is actually the surgeon's decision, absolutely, depending upon the age of the patient and many other factors. But for the clearance of the bolus, the motility or the contractions of the circular muscles is one of the thing, the last thing in my slide. The most of the things are the bolus is pushed down by the cricopharyngeal muscles. The esophagus is, the ileus is pulled up by the contraction of the longitudinal. See, if you see any high resolution manometry of the achalasia cardia, you'll always find that the lower esophageal sphincter is pulled up in the tracing, at least 3-4 centimeters. That means the longitudinal muscles are helping for the bolus to clear. So, and the density of the bolus, the fluidity of the bolus, whether you are lying down, your posture. So everything matters for the clearance of the bolus. And the last thing is the esophageal motility of this, which is what we can say that there is and that is why the esophageal motility index has been raised to 70%. Even if the 70% of the peristalsis have failed, still it is acceptable as normal, because 10 to 15% of these normal individuals, they will have the failed peristalsis like that. So, but they are not abnormal. They are having their food every day.
So in that background, is there any role of barium swallow nowadays regarding the clearance, to assess the clearance, whether it's happening?
Yes, barium swallow is a good way of timed. Nowadays we say the timed barium swallow, so that we can know how barium is clearing properly or not. It's a very good way. Yes, I fully.
And what Dr. Bhimanyu was talking about in CT was probably was thinking of pseudoachalasia. If you're suspecting pseudoachalasia, then probably CT is a good option. So my last is I read somewhere about a 360-degree pressure profile of the LES. I don't know, is it useful or is it done nowadays? Or maybe it is just a research thing which I read somewhere.
Our regular manometry HRM that we are doing,
yes,
it is 360 degrees. It is a spatial type of manometric examination. Spatial, it is all around. So it gives us 360 degrees everything.
Right.
Sir, one technical question, Vijay sir. How do I sure that it is objectively sure that it is I have done a floppy Nissen fundoplication on table?
You have to do our usual maneuvers. The G junction has to be below. You put a tape sling around the G junction. Then you do a shoe shine maneuver and the lifting and all. So that is the floppy fundoplication. The only thing is that
No, but objectively, I mean that is it too tight or it is too loose like that? How can I be sure on table?
No, you can just pass an instrument between the esophagus and your fundal wrap,
Okay.
and you can just see. So what happens is often actually the wrong part of the fundus is taken for the wrap. So
Okay.
rather taking the posterior side, at times the anterior side is taken or the wrong side is taken.
Okay.
Then the fundoplication becomes wrong. But then if you are say about 3 to 4 centimeters from the G junction, lower down along the greater curvature, and then 4 centimeters from there, then you take a posterior part of the stomach, and then there is no problem.
Sir, do we use routinely esophageal bougie?
No.
Okay.
So that
Sir,
was
any
probably the
with-
points which are not part of this talk. We had requested sir to cover the investigations part.
Yes,
Not
I
the-
was.
Oh,
I was
sorry,
told.
sorry,
Roshan,
sir.
Roshan
Sorry.
wants to say something. Yeah.
Sorry,
Just wanted
I
to-
thought it will be more focused on hiatal hernia and technicalities.
I
Sorry.
was
We have
told
another talk.
specifically to not to talk about the surgical aspects. Clear.
Okay. Rajdeep, you have to inform me before that.
Sir,
But very interesting, sir.
One question.
Yes.
Any experience with flip?
Yes. Actually, I told you that the flip has recently come and now it is getting popular also. The flip is used as an adjunct for the HRM. So far, it has not replaced the HRM. And we can know actually flip is the distensibility index. So if there is a stricture, you put a balloon inside the stricture and you put some water and see how much pressure is generated and how much this stricture is dilated. So that is a distensibility index that we calculate. HRM is giving far different information than this flip. But of late, there are some literature saying that the flip is also used in the GRD diagnosis, but it is coming as an adjunct. It has not replaced the HRM.
I think some centers are using even on table per op to assess, the tightness and everything, the distensibility of the esophagus, all those things.
Yes, it is rather more useful if you are operating an achalasia. And see, any compression around the esophagus, it can give the index. It is an expensive tool, but then yes, it is getting popular nowadays. More for the achalasias.
Thank you, sir.
So I think time is over. Rajdeep sir.
Yeah, so thank you very much. I think, yes, Dr. Roshan is here. If you'd like to talk about the upcoming programs.
I'm not aware of the programs what is coming up. Actually, Rajdeep, can you
So,
highlight?
I think
Yes.
technical team has got some slides.
Yeah.
Go ahead. So we have the upcoming AMASICON in Jaipur on 28th to 31st August. Anybody who is left behind, encourage all of you to register for that. We'll be continuing the discussion on GERD, hiatus hernia, and all the technical points which Dr. Abhimanyu was asking would be clarified over there also. Next, please. Where's the next slide, please? Yes. The 117th Masi skill course is being held at IIMS Guwahati. Dr. Jayanta is part of that, and he's just told me that we already had more than 100 registrations. So it's going to be a very successful one. If you wish to join in, please do register. The link is given there. It's also available at our website, amasi.org. Next, please. The next Amasi Online CME will take a deep dive into the management of fistula in ano. It will be in August, the first Thursday of August at 8 p.m. same time. And we have Dr. Balu Kupaswamy and Dr. Samrat Jankar talking about it. We'll be having 4 topics ranging from the anatomy, the lasers, the surgical management. All of these points will be covered during this next online CME in August. Next, please. The next MASI on the LENS program will be on the minimally invasive treatment for prolapsed hemorrhoids. And Dr. Antonio Longo, who is the person who devised this procedure and popularized it, will be giving a live demonstration or a deferred live program. This will be on 17th of July at 7 p.m. This is Indian time. Thank you very much. It's a pleasure for me to thank Dr. Vijay Borgaonkar. He's given an excellent talk. He's very well known in the field of upper GI, and he's doing a lot of other procedures also. The president of HSI. Thank you very much, Dr. Borgaonkar.
Thank you. Enjoyed everything. Yes.
Thank you.
All
Thank you,
this.
sir.
Thank you all.
Thank you. Thank you.
Thank you very much.
Thank you.
Thanks to Dr. Roshan Shetty, the Secretary of AMASI, Dr. Abhimanyu Basu, former Secretary of AMASI, Dr. Ajay Srivastava, President of the West Zone, Dr. Jayanta, President of the East Zone. Thank you very much, all of you.
Thank you, sir. Thank
And
you.
last but not the least, I thank Merrill for their participation and their continued support to our program. Thank you very much. Thank you.
Thank you. Bye.
Thank you.
Welcome to Merrill Endosurgery, your one-stop surgical solution empowering excellence across oncology, bariatric, thoracic, gynecology, urology, gastroenterology with innovative and reliable instruments. From precision cutting tools to advanced energy devices, we deliver comprehensive solutions for modern surgical needs, ensuring safety, efficiency, and superior patient outcomes. Introducing Mirus, range of stapling products. Powered endoscopic linear cutter. Endoscopic linear cutter. Linear stapler. Linear cutter. Circular stapler. Hemorrhoid stapler. Monic trocars. Eliaro trocars. Eliaro bladeless trocars. Mesic energy device. Mesic compact ultrasonic. Mesic ultrasonic. At Merrill, we don't just innovate, we empower. Together, let's create more to life.